And welcome everyone. It's great to see such a great turnout. So um, I'm pleased to introduce Dr. Megan O'Connell, who's presenting today. Um, Megan is a professor in the Department of Psychology at the University of Saskatchewan. She's the clinical director of the Rural and Remote Memory Clinic at the university, and she's also the clinical psychologist in the memory clinic. The clinic has always been in person, but over the last couple of years, because of the pandemic, it's been offered virtually. Dr. O'Connell does research on neuropsychological measurement relevant to dementia and evaluating telehealth for caregiver support and interventions like cognitive rehab and sleep and so on. And she'll be telling you more about that. She has a big focus on technology to support people living with dementia and caregivers. And she's also the lead of the video therapy analysis lab at the university. So we're really happy that Megan is here today to talk about when to refer to the various rural and remote memory clinics. So I'm going to turn it over to Megan.
Wonderful. Thank you very much, Deborah, for that introduction. So I'm going to start talking about the memory clinics. Just to put it in context, CCNA Team 15 has two lines. One of them, of course, is also shared by primary healthcare grant to Deborah Morgan as PI and is under the RaDAR mandate. And of course, you all know about this because many of you are likely in the rural memory clinics. But I'm going to talk a little bit about a different model that we've been working on in CCNA Team 15, which is a centralized model for rural dementia care. And this is dementia care that uses technology to reach rural families. And there are two main parts to this. One is the remote specialist diagnosis piece. And I'm going to talk a little bit about when to refer to us at the memory clinic. But then I'm also going to talk about the work that we've been doing with the interventions that we can deliver remotely, i.e. you could be referring your families to us. They don't have to come to Saskatoon and we can be working with them. I want to start, however, with diagnosis. And in part, I'm going to focus a little bit on when in the diagnostic process you might wish to refer to a specialty clinic like the RRMC. So typically presenting dementia can be diagnosed in primary care. This is the whole premise underlying Deborah's grant and work in supporting primary care memory clinics. However, atypical presentations should be seen by a specialist or specialty clinic. And I've created a little flow chart about where you might want to make some of these decisions. And in it, I say the RRMC, which stands for the Rural and Remote Memory Clinic. But I have to say that we're not the only specialty clinic here in the province. In fact, there is a specialty memory clinic in Regina. And for many of your families, if it needs to be an in-person assessment, that might make a lot more sense just in terms of travel burden. So I just want to say that. I'm going to say the RMC, but it's not just us. However, I will tell you how to refer to us if you do want to. This flow chart that I'm going to go over rather quickly, just because I have more content than I really have time for in this presentation. This flow chart begins at the diagnostic decision-making process after you as a clinician have ruled out any possible medical causes that could have caused the presentation for the person that you're seeing to rule out the diagnosis of delirium. So I just want to say that comes before you even get into this flow chart. So this flow chart is something that I've thought in my head, and this is kind of how I operate clinically. And your questions will help me see where I have some gaps. So I'm going to go through the flow chart in detail in each of these aspects. And we'll start here with the patient demographics. So in the most recent guidelines for the Canadian consensus on the diagnosis, treatment, and management of dementias, primary care should not be the site for diagnosing young onset dementia. And young onset dementia is defined as those under the age of 65. Merely by nature of having a diagnosis or dementia presentation under the age of 65, that is now considered an atypical presentation, and all people under the age of 65 should be seen by specialists and diagnosed in specialty, not in primary care. So that's the first part of the little diagram. That's pretty easy. Now let's get to the next part of the flow chart diagram for your diagnostic decision-making processes are about the neurological findings. And are there positive neurological findings, such as lateralizing signs or other issues? And are these consistent with a history of stroke? If not, you might wish to refer. If they are, you still want to go back into our flow chart because you can probably be making a diagnosis in primary care. There are positive neurological findings that are highly suggestive of atypical presentations of dementia. Although Parkinsonism is a feature that is common, of course, to Parkinson's disease, but also to other presentations of dementia, like the diffuse Lewy bodies. But if you see apraxia, please refer to a specialist. Cortical basal degeneration or progressive supranuclear palsy, these kind of things really are atypical presentations that should be diagnosed in primary care. Sometimes Parkinsonism is a feature of the frontal temporal dementias. Again, atypical presentation, you're going to want to refer to a specialty clinic. If, however, you have features of Parkinsonism, and clear features of diffuse Lewy body, and I'll talk about what those are a bit later, you could likely diagnose diffuse Lewy body. It's not an atypical presentation of dementia. It's probably fairly easy to diagnose in primary care, in part because of the features of Parkinsonism and the likely visual or other modalities of hallucinations that you do see in diffuse Lewy body. But I will talk about diffuse Lewy body again later. For the most part, though, outside the history of stroke and lateralizing signs from your neurological evaluation, in all likelihood, somebody with positive neurological findings is likely going to be needing to be referred. As those of you who are diagnosticians, you know that the frontal release signs, et cetera, things that come out from the neurological exam really are typically negative when you're diagnosing dementia. It's not until quite far along that you might see some of those frontal signs come out, unless, of course, it's an atypical presentation. So then after the neurological findings, which, as you can tell, they're up really high on this decision-making chart, in part because they can drive the diagnosis. For instance, if there's apraxia and it's outside of the FTD rubric and maybe more cortical basal degeneration, that kind of drives the diagnosis. But the next feature that I use, or we use fairly frequently, is it an amnestic presentation? So is the presentation somebody who has problems predominantly in memory? Now, this can be challenging if you don't have any testing data and you only have interview data, because everybody comes to the clinic reporting memory problems. And sometimes you figure out that those are not memory problems per se, but they're attention problems or other more fundamental problems. I've even seen people with language presentations of dementia describe it as memory problems. So you've probably seen something similar. So deciding if something's an amnestic presentation in the absence of the types of testing that I can do, which is testing their memory, I know it can be really challenging from your cognitive screens to get a sense of this. But sometimes the amnestic presentation is very evident from interview. They constantly look to their spouse or other collateral informant in the interview. They're very vague historians. There's stories of forgetting within minutes. There's some things from clinical interview that are fairly obvious, and you can say it's an amnestic presentation. So assuming it is an amnestic presentation, then we start to go, okay, well, are these problems they're having with their memory and maybe with other areas of cognition, are these enough to impact their daily functioning, their independence in daily life? And to do this, I know that in the PC data algorithms that you have embedded in your flow sheets, you do have some scales for this, but we also get at this from clinical interview as well with a collateral informant. One of the features that's very common, particularly in amnestic presentations, is being able to report with any degree of accuracy about your own functional problems when you have amnesia is pretty hard. So that collateral informant is very critical. So if they don't have functional impairments, and all of your testing suggests that there's a couple of different diagnostic considerations I'll talk about. And if they do have functional impairments, I'll talk about what that means in a moment as well. So if they don't have functional impairments, I say here, consider subjective cognitive impairment. And this can be really hard, I think, potentially to make. And of course, I'm biased because I have neuropsychological testing data, and maybe you guys are much better at able to do this without a neuropsych battery. It can be really hard sometimes, though, if you are looking at people's cognition and you're only giving them cognitive screening tests, because as you know, these tests were designed to be pathognomic. If you did poorly, it told you something, but if you did well, it typically doesn't tell you much. And that is the nature of unfortunately, of our cognitive screening tests. So if you have clear from your evaluation, from your interview, from all your objective data that there's no impairment, if this is a subjective problem, then you can diagnose, or I call them, we don't use this as a diagnosis, but it is a category that is of interest, particularly in the literature, which is this construct of subjective cognitive impairment. We used to call these people the worried well. They're much more likely to have psychiatric conditions as well, but not exclusively. But I would say if you see somebody, they don't have a lot of functional problems, but they are quite worried about their cognition, and on your screening tests, you don't know if there really is a problem or not, this would be a great case to refer to specialty clinic to go get some of that specialty kind of additional assessment of their memory. And I'll tell you a bit about why that's so critical later. So back to our flow chart about amnestic presentations and considering the different decisions that you make after you decide if there are functional impairments. What if somebody also, again, does not have functional impairments, but you do see evidence of problems in their cognition on your standardized testing, particularly your screening tests? And you can decide if it's a multi-domain problem. So they might have not just problems with memory, because remember this part of the flow chart, we started with memory problems, because they could have problems in accessing semantic store. So word finding problems that are quite extreme, not those that we start to see in our 40s that just get worse with age, sadly. But other problems, maybe executive function problems, other kind of problems. And that would be a multi-domain amnestic mild cognitive impairment diagnosis. Or it can be a single domain amnestic mild cognitive impairment diagnosis. So I'm going to say if it's a multi-domain AMCI, that's somebody who they might actually have dementia, but the collateral informant isn't ready to report about functional problems. These are some people you're going to want to follow very closely, because these are the type of people who have essentially 2 or more domains of cognitive impairment. And the only thing that's stopping them from having a diagnosis of dementia is that objective or the collateral informant report of functional impairment. So they're going to likely transition into dementia, go over that threshold into functional impairment fairly quickly. So you're going to want to follow them very closely. If, however, it's a single domain AMCI, you're still going to want to follow them fairly frequently. And why do I say this? I say this because AMCI, the transition rate to diagnosis of dementia due to Alzheimer's is very high, and it's just really a matter of time about follow-up. So the follow-up rates are really high, so high, in fact, that if these people had evidence for a high beta amyloid burden in their brain, say from PET scanning or other types of biomarker supports that we don't typically do here in Canada, but are done regularly in the United States, that we would actually be diagnosing these people with MCI due to Alzheimer's disease. So this is a group that is seen as very likely the prodrome to the diagnosis of Alzheimer's disease. But we don't do that in Canada without the neuroimaging support from the biomarker data. So going back to our, again, amnestic presentation and considering functional impairments, now we get into the spot where you're likely doing, or ideally doing, most of your diagnoses in the primary care setting, which is dementia due to Alzheimer's disease. And it's very frequent for people to have vascular complications, and maybe not even stroke history, but much more the watershed white matter tract involvement that might even show up on a CT head scan, certainly will on an MRI head scan, although CTs are getting better throughout the years. So the vascular contributions might mean a mixed diagnosis of Alzheimer's disease and vascular disease. And however, that you can also just diagnose the Alzheimer's disease. The management doesn't differ if you have a diagnosis of mixed vascular versus Alzheimer's. You're always going to want to recommend managing cardiovascular risk factors. And if you feel cholinesterase inhibitors are appropriate and warranted, you would still give these even if it is a mixed diagnosis. And of course, if you're not sure about any of this, is when you should refer to a specialty clinic. So let's go back. So what about this group here if it's not amnestic? So the amnestic presentation, at least if that's clear to you, it's fairly, I think, simple diagnosis. When it's not clear, that can be hard. So certainly refer if it's not clear. And then if it's not an amnestic presentation, we have numerous other potential things to consider. So if it's not an amnestic presentation and the problems are mostly in the behavioral domain, such as personality changes, that is an atypical presentation. FTD or frontotemporal dementia, whether it be the behavioral variant or frontal variant of frontotemporal dementia, should not be diagnosed in primary care. That's an atypical presentation that a specialist second kind of opinion should happen. And similarly, although quite different, if the problems are more in language, and I mean language, not just slight problems, as I said, with word finding problems that we all have, and access to semantic store is impaired in Alzheimer's disease, we know this. But when you have real difficulties making yourself understood or understanding others, these can be problems indicative of the other language presentations that are in the FTD rubric, such as progressive non-fluent aphasia or semantic dementia. And, or believe it or not, in the aphasia category, there's also a presentation that the pathology is actually Alzheimer's disease pathology, but it presents much more in the language domain and logopenic variant. Or logopenia would be diagnosed at that point. Again, not a typical presentation. So if the problems are mostly behavioral, and I don't just mean small behavioral problems, we do see behavioral challenges. In fact, apathy, which can really look like depression, but is not depression. Most people self-report it as depression, but if you actually ask the interview questions about mood versus behavior, you see the difference between these two constructs. And apathy is really common, in fact, a prodrome, and really predicts progression from MCI to Alzheimer's disease, for example. But it really probably precedes a lot of the other problems that are in the Alzheimer's disease process. So I'm not talking about apathy. I'm talking more about like personality changes and radical differences in their presentation, and might even, and in fact, we frequently see this, is people who've been diagnosed with a new onset bipolar affective disorder. They look like they're manic, or a new onset polysubstance use disorder, or something that's a new onset. So your index of suspicion for these behavioral changes really should be high, and you can either refer first to a psychiatrist and then to us, which is what we do see, or try both and refer to a specialty clinic. So these are the types of presentations that should be diagnosed by a specialist or specialty clinic ideally. But there's a whole bunch that aren't. So we're going to talk now about non-amnestic presentation and thinking about people who have more problems in executive functions. Is that misspelled? I misspelled it last night when I created this. Anyway, I think I fixed it here. So if you have more executive functioning problems, and I will say that the cognitive screening tests do a really poor job of measuring executive functioning problems. To be really honest with you, even a full neuropsychological battery where we have a lot of executive function data is not phenomenal at picking up some subtle executive function problems. It can be a real challenge in this domain to assess, in part because the tests are so sensitive to more fundamental problems. So if you have a problem with language, you're going to show up as a problem in all the executive function tests, but not because you have a problem with executive function, because you have a more fundamental problem. So they're very sensitive to more fundamental damage in the brain, but they're also, people can use strategies and organizational systems and ways of managing their behavior, which includes a structured assessment process, which can help mask subtle dysexecutive problems. So it's not until they become a bit more extreme that they sometimes get diagnosed. So I recognize it might be hard, but you get a sense of it when you talk to people about the types of problems they're having. And you do have some types of tests and some aspects of the current commonly used cognitive screening tests that do look at executive functioning. And think pretty highly about vascular contributions. And again, it could be a stroke history where you have the classic cortical vascular dementia. More frequently, however, particularly for people who have untreated chronic hypertension, you're going to see kind of more subcortical changes in the white matter tracts that lead to this disconnect between the regions of the brain and the frontal lobes that lead to a dysexecutive syndrome. So you can see this dysexecutive with people who have more white matter disease, and that's due to vascular contributions. And it's typically hypertension over several years, although not exclusively. Are the problems executive? Yes. Are there other cognitive problems too? And do you have functional impairment? No, then we would diagnose this thing, which is way more heterogeneous than the other MCI, which is non-amnestic MCI. And this group does not progress in the same way. They are not a prodrome to getting a diagnosis of Alzheimer's disease. And they're quite heterogeneous. And I'd say that they mess up a lot of the literature on MCI and progression rates because they're very different beasts. And some people just constantly have a new area of impairment in executive function stay stable. And for some, of course, it is a prodrome or the early signs of a dementia. And in fact, when Peterson proposed mild cognitive impairment in the early 90s, he postulated that there would be a mild cognitive impairment for Alzheimer's disease, which is the AMCI, but there might be a mild cognitive impairment for diffuse Lewy body and all these other types of dementias. So this premise makes a lot of sense intuitively, but this group is challenging, I will say, and they are not the same in terms of progression rates as the amnestic group is. So back to our big screen, our big flow chart. Let's think a bit more about problems here. So are there executive function problems? We're starting with the non-amnestic presentation. Are there other cognitive problems too? Is there functional impairment? Yes. Do you have other features in your clinical presentation? Pretending I'm the patient. Hallucinations, typically well-formed visual, but not exclusively. We do see hallucinations in other domains. Is there evidence of REM behavior movement disorder, which is essentially acting out your dreams? And frequently those people have already been seen by neurologists because in fact, REM behavior movement disorder can precede the diagnosis of diffuse Lewy body, even Parkinson's disease by very many years, like 30 or 40 years. And it has been recently proposed. It used to be an associated feature of diffuse Lewy body disease, and now it's come in as a core feature. And it's sometimes even been speculated in the literature as the prodrome, much in the way that we see amnestic MCI as a prodrome to Alzheimer's disease. There's some speculation about REM behavior movement disorder this way. So they're more frequently getting followed by neurologists earlier on. And then fluctuating attention, which can be really challenging to get at from interview. And I use the Mayo fluctuating attention scale, and some of the questions in there do help separate that. And if you're not sure, again, refer to a specialty clinic. But if they have these features and they have executive function problems and other problems and functional impairment, you can diagnose diffuse Lewy body disease in primary care. I know it's not in the formulary, but cholinesterase inhibitors have been shown to work quite well with this group. And of course, not that you're using first generation antipsychotics, But there, for many years, again, in the early 90s, it used to be very common that this diagnosis needed to happen because the older generation antipsychotics could lead to problems when somebody had diffuse Lewy body disease and really cause some challenges. But I don't think people are using these types of antipsychotics as much. We now use things like risperidone, et cetera, which don't seem to have these problems with diffuse Lewy body disease. So what if, so this is a little flow chart. You'll have to ask me some questions. I quickly kind of created this. It's always in my head. I'm sure I'm missing pieces and your questions will help me with that. So that's going to be great. But what if your person doesn't want to come see a specialist? They don't want to leave their community. So I know from the evaluation data that Deborah has led with the primary care memory clinics, this is one of the pieces of information we hear is families really appreciate staying where they are and they don't want to come into the city to see people who are, well, urban in the city. So I would encourage you to still reach out to us, because one of the things the pandemic taught us is we can do this remotely. And I don't really know what we're doing going forward. One of our evaluation pieces of the virtual memory clinic, and one of the things that I'm considering as co-chair of the telemedicine or virtual dementia care group that's happening at the CCNA level, is post-pandemic, when should we continue to provide these remote services? Because certainly many of our families really, our evaluation has suggested they love the remote version. And I'm sure for those of you, you have many people in your own settings that would love love the remote version. So thank you, Dawn. I see that you put that up. I was going to actually show you what this looked like. And that is right here. So Dwayne had put in the chat the link to the remote memory clinics, and then there's a referral form here. So that's very helpful. The other thing, particularly if you're trying to figure out if somebody's presentation is amnestic, you don't really feel like your testing tells you that much, because that can happen, particularly with memory problems, or you have somebody who is complaining a lot but does really well on all of your screening tests, which again can happen, as their screening tests are highly skewed and don't pick up subtle impairments. Maybe consider referring your patients to the remote neuropsychological assessment pilot. And you'd still be responsible for the diagnosis and all these other features of the assessment, but you get the one piece you can't get, which is a brief neuropsychological assessment. So the link for that is also here, and Dwayne's also put it in the chat. And this is just a pilot for now. So not going to be going on all that much longer, but we are looking for funding to make this a permanent clinic and a permanent evaluation project. So, and again, as a method to support you in making your diagnoses in primary care and not take away that diagnostic process, but only give you the one little piece you might need, which is a more fulsome assessment of cognition. And why would you need that? Well, partly because of what happens to our brains as we age. This is a review done by Cell Health, cross-sectional longitudinal data, robust, thousands of studies. Cognition, particularly memory, changes with age such that it declines. This is considered normal aging. So one of the big challenges with very subtle amnestic presentations is it normal aging? Because being forgetful, look at this. Look at our lovely chart of what happens to our brain. Our thinking speed goes down, our reasoning goes down, our memory goes down with age. And this is normal. So we have to be able to separate normal aging related changes in cognition from pathological or outside the rate of change that's typical. And that's the one feature that a neuropsychologist can do, because we have tests that aren't so skewed like screening tests, and they are normed or compared against people who are similar in age. Vocabulary reason, isn't that great? We do have some stuff that goes up with age. But again, this is just considered normal human aging. And as you know, also that in that aging process, it can be really hard to tell the difference between this normal aging trajectory of cognitive decline for many features of cognition, particularly memory, from the trajectories that might be suggestive of something more serious. And that one little piece that can help that might be the neuropsychological evaluation, although it's only one small piece of the big picture, I recognize. So I talked a little bit about the diagnosis and when you might wish to refer your patients and families to a specialty clinics such as the Rural Memory Clinic, which we might be able to continue to do remote or virtual visits if that's a strong preference for your families. But I'd like to now talk about the other project that we've been doing, which is the RRMCI interventions. There's a suite of interventions, and we deliver all of these remotely, and even did before the pandemic. So we can be seeing your families. They don't even need to have technology. They might just drive into the local telehealth suite, but if they happen to have the ICT technology and the bandwidth availability in their own home, they could do these interventions in their own home. So let me tell you about them so you can make some decisions about whether or not you think this might be helpful for any of your families. So one of our projects that we've had going for few years now anyway, is an insomnia intervention. And part of the reason why I started this project is because I see so many people in the memory clinic who actually I end up diagnosing with that thing I called subjective cognitive impairment. I see a lot of these people and they come in because they have insomnia. And there is a dose-dependent relationship between attenuated, but not impaired, but attenuated neuropsychological functioning and sleep disturbance. And for any of you who've ever experienced sleep disturbance, you intuitively know what I'm talking about. But let's think about chronic insomnia. That's defined as people who've had these problems for over 3 months. It doesn't matter if it's onset insomnia or maintenance insomnia. It doesn't matter if they have obstructive sleep apnea, provided they are treated with consistent use of CPAP, then this intervention is appropriate for them. We can't give this intervention to somebody who has apnea not using their CPAP. Unfortunately, it's contraindicated. These people that we're willing to work with can have subjective cognitive problems. In fact, that's why I started this in the first place, or they can have objective cognitive problems. And we've been adapting this intervention for working with people who have more profound cognitive problems, particularly dementia. And it's also suitable for caregivers of persons with dementia. So frequently, in some of our own work has suggested this as well, is sleep disturbance by the caregiver is one of the reasons for decisions to admit or at least explore admission into long-term care. It's very, very challenging to be a caregiver when you're not able to sleep for numerous reasons. So I have no doubt that you are seeing people in your clinic who have sleep disturbance. And the frontline treatment for this back in 2016, at least by the American College of Family Physicians, was decided that it's not the sleep meds that you prescribe, and certainly not the over-the-counter anticholinergics, which are dementia risk in their own. But it is in fact this thing called cognitive behavioral therapy for insomnia, or CBTI. And for this reason, numerous other types of specialists, including psychiatrists, are learning how to do this intervention. It's very effective. Its effect sizes are massive, but of course it does require people to want to change. So please refer. They don't have to have any objective problems. They just have to feel like they're not cognitively well and are worried about their cognition for you to send them to us, and we can make a huge difference in their life if they decide to engage in some of the behavior change. That's part of the CBTI. We also have another in our suite of interventions is cognitive rehabilitation, and we deliver this remotely. So this could involve structuring someone's environment in a different way, reorganizing their iPad so it's not so confusing for them to use now that they have new onset memory problems. Simple things like this, but and using spared memory systems to help people who have amnestic MCI or dementia due to Alzheimer's or other problems function better in their daily lives. It's very highly individualized. So it's one-on-one therapy with a family and a person with MCI or dementia. And it can involve retraining, using cognitive rehabilitation techniques to learn names. It can involve some simple and powerful interventions like using a memory book that can increase socialization, etc. So there are so many things that can be changed by cognitive rehabilitation. And it can be quite powerful in terms of making a difference in someone's life. There are no disease modifying interventions for dementia. It doesn't matter what the etiology is. Cognitive rehabilitation is not a disease modifying intervention, but it does help make a difference in person's day-to-day life. I also put in a request for you to think about cognitive rehabilitation, because I do have a sub-project under that one of my PhD students is doing. And one of the things that we've been really interested in is how can we use off-the-shelf technology like the Alexa systems or smartwatches, et cetera, to augment cognitive rehabilitation? And how can we use off-the-shelf technology to help caregivers care for a person living with dementia? So, you know, I was very inspired by a caregiver who's part of a caregiver advisory panel, who used off-the-shelf technology to help stop his father from wandering when his father was beginning to wander, because of course you can drop in on somebody else in another room or monitor them remotely, privacy issues aside, obviously, and it really depends on what works for any particular family. But we have had some experiences where being able to monitor, or at least monitor where they are, or monitor if they've alerts from sensors, if they've left the house, have been able to help caregivers manage the anxiety and the constant vigilance that they need to engage in, particularly when they're spousal caregivers and live in the same home. Technology can help mitigate some of those challenges. So please think about any family. I'm willing to drive down to wherever we need to go to install this in their home to help my PhD student get a few cases for his study. Another project by one of my other PhD students is one that we're also recruiting now for, is a social network intervention for caregivers. So it's delivered remotely, so nobody has to come in to Saskatoon. And we're aiming this at caregivers of person with cognitive problems. So they can be a caregiver of somebody with undiagnosed dementia. So you must have some people like that in your caseload. Their loved one doesn't want to come in because they don't want to get assessed, because they don't think they have a problem. That's very common. It takes a lot of patience to get somebody to decide to come in. And of course, you in primary care are more likely to see them than I am, where we're in tertiary care, not a group I know how to help. So other than time and having them trust you that a diagnosis is a good thing, I don't have any quick answers for you. So you might have some caregivers who are that, and they're welcome to come into this intervention as well. And this is an intervention that is individual therapy. So in contrast to the CBTI and the cognitive rehabilitation, those are much more behavioral. This one does deal a bit more with emotions. So it is a bit more traditional in that sense of what therapy is from a psychologist. And it's based on interpersonal psychotherapy, which is a type of psychotherapy that focuses on your relationships with others. And here in particular, it's really powerful. I mean, I think we should all have IPT for increasing our skills at communication. But for caregivers in particular, I think it's really helpful for teaching them how to communicate their needs, so that when they do ask for help, they get the help they want, not the help they don't want. So because caregivers ask for things, and they're not getting the help they want, they begin to stop asking and they begin to restrict their social networks. So we do know that this is a common phenomenon from the literature. Sometimes they also need to assert boundaries with others in their network, whether that be based on how they're doing at the particular time or other issues in their networks, because families exist in these networks, and dementia can be added upon a very complicated network, which just exacerbates all these challenges. And more importantly, in the end, is helping caregivers expand their social network in ways that works for them, figuring out who can provide me with what support I need so I can get the emotional and tangible support I need to help me with the caregiving. So if you can think of any caregiver in your life, in your clinical practice, who is challenged and has mentioned being lonely or feeling like everyone disappears, because I know I hear that a lot from caregivers, please see if they're willing to, engage in some therapy done remotely with a really great guy to help them with those feelings. So that's a study I'm recruiting for now and would appreciate help with for sure. A project that we're about to begin is one on driving cessation. So we don't fully have our ethics. Oh, we do have ethics. We just don't have the training from the psychiatrist, the geriatric psychiatrist who's helping us with this. So we're probably putting this off into the fall. But being asked to stop driving, first of all, is very challenging to give as a care provider, and you all likely know that. And managing the anger, the frustration, and the loss of identity associated with this, and subsequent, isolation, depressed mood, etc. So we're working with another team in CCNA to help develop a type of therapy to help people mitigate these problems that they have psychologically post being asked to stop driving, or people who are considering the stopping driving. And that's because this can, as you know, be a very challenging time. And there are very few driving specific supports, particularly for the emotional consequences of being asked or forced to stop driving. And it is a very challenging psychological time for people. So we're going to likely begin recruiting in the fall. We have everything set in place. We just need to get the training to do this work. And then a project that I'm doing, although I'm not trying to recruit any help or participants for, though, is Indigenous Caregiver Support Group. So I've been working with a community research advisory group consisting of several First Nation communities in Southern Saskatchewan, and then working with our caregivers to co-design a culturally safe Indigenous caregiver support group. So I'm not recruiting, it's now a closed group, but the evaluation piece is underway, and I am still continuing to provide the support group with the caregivers. But it's so clear that the generic supports that are provided that are not culturally safe and not designed with and for Indigenous peoples are not working. And this type of support is needed. We're doing this remotely. We got MiFis, which are ways to give a cellular signal in rural areas where cellular signals do not exist very well, and provided technology, trained on use of technology, and have been virtually providing this support group in ways that has been very powerful. And we will be expanding this work, but likely in a different province, at least initially, looking for funding anyway. So that's a little bit about the RMCI. One of the things that's pretty clear at the most fundamental level when doing remote interventions is really understanding what's going on for the family in terms of comfort with technology and access to technology. And that interacts with neuropsychological strengths and weaknesses and sensory strengths and weaknesses. Telephone visits, which I'm sure you all did in the pandemic, don't actually work that well with people who have profound hearing loss. They do better a bit with the video conferencing because they can read lips, but sensory implications can really be a challenge. And we've had some good successes modifying and working with people with moderate to severe, in fact, somebody who's clinically blind, sensory implications, doing this remotely. So I will say that we've had some success doing this. So it can be done. So don't think that one of your patients who has sensory problems or neuropsychological problems are therefore contraindicated for remote intervention. In fact, we do work with them, and we can. We have had success doing that. I had additional things to talk about in case you don't have a lot of questions. So I'm going to leave it there because I do want to give you the opportunity for questions. But if everyone's really quiet, I'm going to talk a little bit about risk factors for dementia, but I'm going to give you an opportunity. I'm going to stop sharing and give you an opportunity to ask some questions.
Hi, Megan. It's Deborah. I was just, there's a lot of information in the algorithm and the flow sheet, very detailed, steps to follow. And I was just wondering if that, could be available to people to look at, because it's a lot to keep in your head. And I know you're just developing it, so I don't want to put you on the spot.
Yeah, no, what I was hoping for was questions from people who are diagnosticians in primary care to help me realize where I've got the gaps in the algorithm. And then I'm going to send it out to our network of specialists, get their feedback, and then it's going to be ready for release.
Yeah, okay.
Not quite ready for release.
Yeah.
It's like the first iteration of that.
Seeking input.
And questions,
I mean,
like, where are the gaps? Where are you lost? What else do I need?
Yeah. Well, it'd be great to hear from people about where their uncertainties are, like, I'm not a clinician, so, is it challenging to tell whether there are functional impairments or memory problems? Sometimes our testing isn't that accurate, or, the informants aren't maybe clear on what the problems are, or how to articulate them, and so on. So there could be a lot of uncertainties along the way. And what should clinicians do when they aren't sure? Should they refer, or I guess knowing where those uncertainties are for people would be helpful, or where they might struggle in following the algorithm.
I think I could see a challenge with that decision point in the amnestic presentation, because everybody complains about memory problems, and it's not until you actually get a bit more of the examples of the memory problems that you realize that's actually not a memory problem. But I actually don't really know that until I do my testing. So I think that would be very challenging for me anyway to do without having some objective testing in that domain. And the challenge, as I said, is the screening tests. When they're impaired, it tells you something, except of course there can be reasons they're impaired that have nothing to do with cognition. So you have to be careful about that too. But for the most part, when they're impaired, it tells you something. When they're not impaired, it's kind of really hard because they can still have a problem. It can be subtle. And that's where you probably need a bit more of a objective assessment that's beyond a screening test.
I was just thinking that I would hate to see people not refer because they were unsure if they were, following the algorithm correctly. Because if
right, exactly. And I would say anywhere in there, if you're unsure, refer. That's the final message. I should just stamp that over. If you're unsure, refer, right? It's really like, that's the, if you know it, great, use the algorithm. If you're not sure, just refer.
Great. That's kind of what I was wondering. Yeah. But if people have any thoughts about it, they can email you, or jump into the chat, or just speak. But any kind of feedback would really be helpful, because I know it's a great resource to have this, and the more we can fine tune it and make it usable and accessible for people, the better.
Well, I've had enough experiences giving remote presentations that I anticipated this potentiality. So I did prepare an additional little presentation, in part because of where most of you work, which is in primary care. I assume all of you, in fact, do. And I think that these messages may have trickled down to you, but may not have. So, and this will also give you an opportunity to ask more questions. Although I will say that it's not an area where I'm as familiar as the other ones. So one of the things that I'm not sure if it's trickled down into primary care, although it has certainly been in the literature for quite some time. We do know there's this research to practice gap, and this may in fact be one of them, is the really compelling cumulative evidence that use of anticholinergics medications do increase people's risk of dementia. And unfortunately, this is not just the anticholinergics that we diagnose, such as, But it's also some of the over-the-counter. So anticholinergic ones I frequently see are ones used for urinary incontinence. So that is prescribed a lot. So thinking about that and the challenges with that. But there's a lot of over-the-counter anticholinergics that people take, such as the first generation antihistamines like Benadryl and some of the sleep medications. So I would encourage you, particularly if you have somebody who has a sleep disturbance presentation, not just finding out about kind of what they're taking, but also the over-the-counter stuff, because chronic use of this has been shown to increase dementia risk. And then even more recently, even if you do have dementia, use of this increases mortality. So again, this cumulative evidence really suggesting anticholinergics, whether it's prescribed or over the counter, really are something we really need to start thinking about and considering. And maybe you already have practice advisories for this, and maybe there's already a black box label. I don't know. I don't prescribe medications, but I'm much more aware now of the over-the-counter ones because of this this literature. And of course, because, as I said, a lot of people are using the over-the-counter ones not prescribed for sleep disturbance management. And really the CBTI is the way to go for people who are willing to do it. It's the way to go. So just a little thing about risk factors for dementia, that includes one. And then I'm not sure if you had a chance to read this really influential, amazing article with this great infographic on the modifiable risk factors for dementia throughout the lifespan. So one of the earliest modifiable risk factors is education. We have seen education rates and rates of illiteracy go down around the world, and education rates go up. So we've certainly seen the impact of this intervention on dementia risk as the cohort has been aging. So it's been a very robust finding. But there's a few other things in here that might be a surprise to you, particularly given life stage. So some of these are ones you're like probably knew about. Hypertension in midlife really does predict dementia risk later on. Heavy use of alcohol, obesity, traumatic brain injury. These are probably not a surprise to you. But hearing loss accounts for more variance in later dementia risk than these other ones that we would think about. So I think that sensory loss and really thinking about mitigating the impacts of hearing loss, even in midlife and not waiting till late life, and treating, these other risk factors, which I'm sure you're already treating, hypertension, et cetera, are really critical. And the sooner you do it, the more it mitigates risk for dementia. So this is why it's considered a modifiable risk factor for dementia. We don't have any disease modifying drugs for any of the etiologies of dementia. And I quite frankly don't think I'll see one in my lifetime, which is not that because I'm hoping to live another 40 years. So, so it's not something we're holding out a lot of hope for. And the research and the focus is now really moving into prevention, because if we can't fix it after you get it, can we help stop you from getting it? So hearing loss is something I'm not sure if you knew about, but thinking about adding that to your asking about all of your patients you see in primary care in midlife and beyond, and really helping to think about that. Okay. Then later life, things that probably are not a surprise to you are smoking, physical inactivity. Air pollution is coming out as a really big factor. I will say we're very lucky we live in Saskatchewan. We have great air quality. Diabetes. But what I want to point out is not these ones, because these ones you probably knew about. These are risk factors for dementia. But what I want to point out is social isolation and depression are huge risk factors. And again, I'm not talking about the depression apathy overlap. It is a prodrome, we know that, but I'm talking about depressed and sad mood and social isolation. These are huge risk factors for dementia later in life. And more importantly, these are modifiable risk factors, and we can make a difference. And of course, addressing physical inactivity, addressing smoking, these things are probably, as I said, not a surprise to you, and diabetes always being a problem, in part because hyperglycemia impacts a separate part of the hippocampus, and Alzheimer's disease, and you add them together and it just kind of increases your risk, and it's a cardiovascular risk factor in itself as well. But the social isolation and depression, so thinking about your older adults, And we saw a lot of this in the pandemic. It really became highlighted, but older adults do experience social isolation at higher rates than other age groups. And mitigating social isolation can be a huge modifiable risk factor. So thinking again about these kind of risk factors that you may not traditionally think about when you're working with your older clients, again, this is later in life, can really make a difference if there's a way to intervene in these. So thinking about social isolation, depression, really consider referring your clients or patients to a service such as the one we're offering, or at least we're researching now, which is a social network intervention, in part to mitigate some of these known challenges in factors that lead to increased risk for dementia. So because of this knowledge of these modifiable risk factors, the research is moving into prevention studies, including worldwide fingers, which you may have heard of, and then in Canada, led by CCNA, the CAN Thumbs Up study. So at some point there'll be enrolling people, and I don't know when that's going to happen. I don't know where it's happening. I do believe this whole intervention should be remote. So that means we might be able to have some remote families involved in the CAN Thumbs Up. So I've got a note from Dwayne saying this is a good time to end so we can do our poll. And I thank you very much for your attention.
Thanks, Megan. I appreciate that we are getting close to 2 o'clock, and we sort of scheduled this session to run for that time. So I'm opening up a poll for some feedback from folks. If you have a chance to just quickly click through those questions so we get some feedback for planning for our next session, that'd be great. And I'm not sure, Megan, if you are able to sort of join if there are any later questions that come in, but yeah, thank you very much, everyone, for joining us today.
And I just want to say thank you as well, Megan. That was really an excellent presentation. And I just want to confirm that the referral forms for all the different RMC projects are on the website, the links that you showed us, so people can refer. And also, just to really encourage people, if you have any feedback, any thoughts about, what issues you struggle with in assessment and diagnosis, so we know, because I know Megan's work is really focused on, addressing your needs and what it is that you need to help diagnose people with dementia. And so the more feedback, the better. And yes, and if these are strategies to try and provide support provincially to healthcare providers, and so knowing your needs is really valuable. And these are things that could potentially become part of the rural and remote memory clinic service permanently in the future if we can demonstrate that there's a need that we can meet here at the RMC. So thank you, Megan, and thank you everyone for joining. It was really good to see so many people taking part, and look forward to any feedback that you have.